Hi, my name is Nguyen. I'm an affiliated faculty member in the Philip R. Lee Institute for Health Policy Studies, and I'm an assistant professor in the Division of Hospital Medicine at San Francisco General Hospital. What I've been thinking about in terms of my research is how to best provide support and assistance to get people back on their feet after hospitalization, particularly among people who are low income. And what I mean by this is thinking about how do we address the social determinants of health? For example, how do we help with unmet health-related social needs, things like housing instability, food insecurity, and transportation? One area I'm actively thinking about right now is exploring the role of prescribing cash to help with post-hospital recovery and improving health. So this is an area that's interesting to me because I'm a practicing internal medicine physician, in addition to being a health services researcher. And in my clinical practice in the hospital, I directly see how structures, systems, and policies affect people's health and their ability to recover after hospitalization. We all know that being in the hospital is a shock to people's systems, and it takes a lot to recover after an illness that makes you sick enough to be in the hospital. The first few weeks after you leave the hospital are a particularly vulnerable period in terms of being able to get back on your feet. Now, imagine not having your basic needs met. This further complicates the process. For example, what if on top of being too weak to cook for yourself, you don't even have money to buy the groceries? Or what if you miss an important phone call from your doctor because you couldn't pay the phone bill? There's a lot of great work in this area on screening people for these types of social needs and connecting them to the right resources. But there are also challenges with this approach. It takes a lot of time and overhead to do that. So my idea is, what if we made this simpler? What if we still make the referrals and do all those things for people who need it, but we also prescribe people a modest amount of cash when they leave the hospital so that they can immediately and directly take care of anything else they might need while they're waiting for longer term assistance to kick in. Some of the implications of this work for healthcare and health policy are that the Centers for Medicare and Medicaid Services implemented the Hospital Readmissions Reductions Program nearly a decade ago, with the idea that 30-day readmissions were a marker of how hospitals failed to do the right thing medically for their patients. Now, there's an emerging idea that if a patient comes back to the hospital within the 30 days, it might not necessarily be because the hospital did something wrong, but because it might be because there are not enough supports for patients once they leave the hospital. Right now, we don't have a good system in place to help people during this vulnerable period, and prescribing cash would be a simple and straightforward way of providing that additional support without a lot of overhead. I think thinking about cash and how to help people really pertains to the additional attention to health equity that's been highlighted by COVID. I think there's been a lot of attention and recognition of the fact that people who are low income and of minority backgrounds have more health challenges and more difficulties once they leave the hospital. And so this work is a natural outgrowth of my previous work, which I spent understanding the impact of structures, systems, and policies on outcomes, as well as on health equity. And this work is really a step in the direction of building common sense interventions to help people when they need it the most.